Okay, Dr. Prakash Marathi, you can present your first talk. Yeah, na?
Hello, good morning, everyone. It's the pleasant morning at Patna here. Most of the ophthalmologists have been doing phacoemulsification, but other type of surgery is SICS. And you have to take the decision whether to go for phaco or SICS from patient's perspective. Sometimes the patient is asking you whether you are going to do phaco or SICS. So when the patient comes to you, probably you have to define yourself. What type of surgeon are you? There are various surgeons classified in these three categories. The first one is you can declare yourself as pure manual SICS surgeon, like Dr. Jagannath Boramani, then few others. They are purely doing SICS surgery. Then most of them are pure phacosurgeons. They treat themselves as phacosurgeons. And third category is they have expertise in both these types, like Dr. Suhas Haldipurkar. They can handle both type of surgeries when the patient comes. When they want to shift the surgery from SICS to phaco or phaco to SICS, whatever decision on the table they can take. Suppose there is phaco getting complicated, they can shift to SICS. So that is third type of expertise. So before tackling to the patient, I think you should define yourself which type of surgeon are you. Next is phaco versus manual SICS. There are few things you have to explain to the patient, both the procedures before proceeding further. I think they talk some rubbish like laser surgery or some dynamic surgery or some different type of surgery in their minds. So what are the pros and cons of both these types of surgeries? You have to explain to your patient. Then suppose he is in two minds, whether to go for phaco or SICS. You have to facilitate for his decision what type of surgery the patient wants to do. Sometimes there is a doubt about costing of the surgery. So for that you have to justify what type of surgery you are going to do and what is the cost. So you have to correlate accordingly why the cost is little different. Maybe it is related to your machinery, maybe it is related to your type of IOL, your type of machine of phaco surgery, and why the cost is little more or little less. There are SICS surgeons charging 1 lakh to 2 lakh, and they are telling that my cost is 2 lakhs. The cost of IOL is only 5,000. 1,95,000 is my skill cost. The surgeon in Pune, Raju Raut, who is my friend, because what he says that it is the skill I am charging you, not the IOL, not the machine. And that's what you should be able to do. Then place of surgery. Suppose where the phaco facilities are not available and you are trying to do phaco, it is not done. Suppose SICS equipments are not available and you are trying to do SICS, no, it is not done. So you have to be well equipped with the type of surgery what you have planned. So the equipments available are very important. If you are doing phaco, all those setup must contain everything in that relation. Sometimes there is the issue of ambulation, very small incision. So that time probably the phaco is motivated by the surgeons and even the patients and relatives, they feel that phaco can be done. But even in SICS now, the ambulation is very fast. In case of insurance, like insurance companies, they are insuring maybe phaco and not SICS. In foreign countries, I think SICS is not acceptable to them in their records. It is only ECC and then phaco. We, under the platform of AIOCMTC1, are trying to say that SICS is also one of the fantastic surgeries, and that option must be kept in mind. Even residents are taught ECCA and directly phaco. So they do not know what SICS is. That's the picture what you have seen in America, Australia. But they also must be taught this type of surgery. Suppose there is some complication while doing phaco, they must be able to shift that to SICS. Recently in Australia, there is one experience. There were hypermature cataracts. They were not able to handle with phaco. One of our Indian doctor went there and showed them SICS. They were pleased. There was so much of crowd in front of that surgeon. What new technique is being delivered by that patient. The whole nucleus was seen. And I think they were amazed to see that technique. So we should motivate that technique to even abroad. So type of lens, what type of lens you are putting, there must be some transparency about the costing of the lens. And then the patient gets convinced and he pays you properly. Astigmatism, what they say it is less in phaco And little bit myopic astigmatism is seen in SICS, but it is better for near vision. Without glasses, probably the patient is able to see. That is a positivity. Multifocality, of course, in PECO and SICS also you can put multifocal lenses. Smart SICS is a technique which is developed by Dr. Rajiv Raut. What he says, even multifocality can be achieved in SICS. What type of surgeon? Accordingly, the type of cataract also you must assess, type 1, 2, 3, 4. And in hard cataract, you can go for SICS. Soft cataract, of course, you have got both those options. Black and brown cataract, phaco sometimes is difficult. Of course, in experts' hand, even they can do phaco in a nice way. So condition of cornea, what they say in phaco, probably it is very well maintained, endothelium and all that. Some SICS surgeons, they say even they can maintain very nice condition of cornea. But transparency of cornea before operation, sometimes if it is good or not good, accordingly also you can decide if there is some opacity in that part of cornea, what type of surgery you are going to do. Sometimes the other eye surgery is also done beforehand. What type of surgery is being done on that eye? Patients have got some hesitation whether to go for same type of surgery or some different type of surgery. If you want to do the combined procedure, I think the type of incision, site of incision may be a little different. And to decide about phaco or SICS is also a very important step. Previous operation on that eye, suppose it is done, again, it decides what type of surgery you are going to do, whether it is SICS or phaco. And I think these all things you must decide yourself as well as patient's expectation to go for phaco or SICS. I think with all this, I have tried to clear your doubts about that type of surgery. With these words, this is my humble appeal to vote and support for Joint Secretary. Thank you. Thank you so much.
Thank you, Dr. Prakash. So, Dr. Abdindu to be ready. But in the meantime, Dr. Prakash, one message is very clear which you have given to us, that you may be a very good phaco surgeon, but still SICS should be known to all. You really never know when it comes to your rescue. And yes, in the country, probably 60% of the surgery is still done by SICS.
Yes.
So it's a very well accepted technique. And now, recently people have started doing a 2 millimeter SICS.
Yes.
Right? So with a snare, you can cut it out and bring it out of 2 millimeters. So if
Dr. Amulya Sahu has been doing that.
Amulya has been doing it. So if you can do SICS out of 2 millimeters, then that is also equally a good future as phaco. And a economical system for the country and for the doctor and the patient.
Yes, sir.
Thank you.
Thank you. Thank you so much.
Thank you, sir. A very good morning or a good afternoon to everyone. I'll be talking about complications of cataract surgery and how to handle it, that is glued IOL in complicated situations. Many times you have situations here where you have a dislocated IOL, a decompensated cornea with an AC IOL or an absorbed cataract. Should we leave this patient aphakic or rehabilitate this patient with good scleral fixated IOL? This is one of the patients who underwent traumatic cataract surgery, and you can see there is an aphakia with vitreous in anterior chamber. There is a secondary glaucoma, and the tensions are pretty high and of around 36 millimeter on all anti-glaucoma medications. So what we planned in this patient was to do an glued scleral fixated IOL with an AGV with total vitrectomy with an pupilloplasty. So this is the patient, you can see the corneal wound here, the vitreous is in AC. So first glaucoma surgeon takes over. He says where I have to put the valve. He chooses the infratemporal quadrant to put the valve. So 8 millimeter behind the limbus, the plate of the valve is sutured, and then 5 into 5 millimeters block of sclera was dissected because we are going to put the valve in the posterior or into the vitreous cavity. Once this procedure is over, then we dissect two flaps. One is supratemporal and another is infratemporal. The flap should be diagonally opposite to get a good centration of the lens. Once the flap is dissected, by 1.5 millimeter behind the limbus, we create sclerotomy. And I use this sclerotomy to do a total vitrectomy. A total vitrectomy with a tricot assisted vitrectomy with PVD induction is mandatory because we are going to put the valve tube into the vitreous cavity, and if I leave any amount of vitreous, it's going to block the tube and the glaucoma surgery will fail. Once the PVD is induced, a total vitrectomy till the equator is done. We don't go ahead and do an base dissection. Tricot is removed, and after that, chariot tunnels are created with the help of a 26 gauge needle. The lens is injected through a clear corneal incision. Important thing here is you catch hold of the tip of the haptic and then rotate. Once the lens is delivered inside the eye, then you externalize this haptic, because if you externalize it before, you can break the haptic. The assistant holds this haptic and the second haptic is externalized. Both the haptics are then internalized into the chariot tunnel, and you can see a well-centered lens. Now, what we do, we create a sclerotomy 2 millimeters behind the limbus and place the tube behind the lens. It doesn't goes anterior to the lens, it goes behind the lens. The flaps are sutured, the scleral patch graft is put, and once all this procedure is done, then you can see the pupil is inferiorly, there is no iris. So I go with a 4th row pupilloplasty. You can see this is an CT S6 needle. The iris is taken and the suture is passed away, taken out from the paracentesis. Now what you see, you have brought this proximal suture
HDMI
out. You have 3 sutures. This is 1, this is 2, and this is the 3rd one. You cut this suture and take the loop from this suture. So 4 throws are taken. Once the 4 throws are taken, then you'll pull this digital suture and the proximal suture. The moment you pull it, the knot gets internalized and you can see a round pupil here. And doing this procedure, this patient achieved a 6/9 vision post-operatively. The flaps are glued, the conjunctiva is sutured. We go ahead with the second case, that is pseudophakic bullous keratopathy. This was a case, you can see here, there is a bullous keratopathy, the ACIOL is here, the pupil is non-dilating. So we plan to do a DSEC with ACIOL explantation with malignant ring with glued scleral fixated IOL. So the flaps are, important thing here is you always have to put an infusion. The flaps are made nasally and temporally. If anterior vitrectomy is done, and you can see the haptic of the ACIOL is almost stuck here. So I gently go to the 6 o'clock position and gently remove the haptic from the scleral tunnel. Once the haptic is removed, a malignant ring is placed to dilate the pupil, because until unless I have a good dilatation, I won't be able to do a glued scleral fixated IOL. So the malignant ring is put, the IOL is then inserted inside the eye. I use a handshake technique to catch hold of the tip of the haptic, insert the IOL inside, and the haptic is then externalized. In a similar way, the second haptic is also internalized and then externalized. Once both the haptics are externalized, a tunnel is created in the sclera, and these haptics are internalized into the tunnel. The malignant ring is removed. Now the pupil is small. There you have a lens diaphragm, and now it becomes an ideal case for DSEC, because you have a diaphragm and a small pupil. On a pre-prepared DSEC lenticule is taken on the Bousson's slide and pulled inside the eye. The air is injected. The lenticule is centered. The flaps are glued, and you can see the post-operative picture of this is day 1 post-operative picture. This is 1 week post-operative picture. You can see a clear cornea, well-centered lens. You You can see an OCT picture, the lenticule is well attached. So to conclude, glued IOL is a viable option in complicated situation. It helps to rehabilitate the patient which otherwise would have been left aphakic. Helps in corneal procedures by providing diaphragm for tamponade for attaching the corneal lenticule. So to conclude, patients which were thought to be unoperable and was refused surgery elsewhere could be operated and rehabilitated because the specialty glaucoma, retina and cornea coming together. And that's our strength. And thank you very much for your kind attention.
That was wonderful, Abhinanda. So my one question, you did all these specialities yourself or you engaged all the other doctors?
It's like first case, Dr. Harsh was doing the glaucoma part, and second case, Ritika was doing the cornea part.
Okay.
So it's a mix of specialty. I don't do all the procedures.
Fantastic, really very well done. Gives a real insight in how much multi-speciality role can help in giving sight to one patient. Thank you.
The good thing was your videos was very nice.
Thank you.
Clarity and very nice. Next, Harshul.
Setting up.
So next talk is by Dr. Harshul. So phaco in brown, black and white cataracts. Cup man.
No, it's there in this. It was working there just now. We did. Abhi, I just presented.
So after Harshul is Dr. Goswami. Dr. Goswami is here.
एक मिनट. ये नहीं आ रहा ना. अभी क्या नीचे यार? हाँ, try that side. Okay.
एक साइड में लैपटॉप लगाओ, एक साइड अपना लगाओ, वहाँ पर लैपटॉप लगाओ.
HDMI.
You allow laptop only one side.
In the meantime, Abhinanda, you said you did vitrectomy only in the posterior half. In your first one, right? And your tube is entering the anterior half.
I did a total vitrectomy for that.
It was total interior and posterior, total.
It was a total vitrectomy and it was a tripod assisted vitrectomy where we have induced a posterior vitreous detachment and removed the total vitreous. So that is, once you are doing a posterior valve or you are placing the valve into the posterior chamber, then you have to do a total vitrectomy. A partial vitrectomy will not help. We have seen cases where we have done partial vitrectomy, the vitreous has come and blocked the tube. So total PVD induction is mandatory in these kind of cases to achieve success.
Okay, so good morning, everybody. I'll be presenting few cases showing phaco in brown, black, and white cataracts. We all know that to deal with these kind of brown, black, and white beauties is really difficult task because they are difficult to crack. So we always need to have a good strategy to deal with these hard cataracts. So the strategy which I use is what I call drill and chop technique, which I presented almost 15 years back and have been teaching this technique. It's very much reproducible. So you always need to protect endothelium in these kind of cataracts because definitely it's going to take more phaco power and more phaco time as compared to normal cases. So it's always better to do specular count and use an OVD which is chondroitin sulfate based and which can coat the endothelium and protect endothelial cells. So once you stain anterior capsule and you go ahead and make a capsular axis of adequate size. So the capsular axis size is 5.5 millimeter around. And so the main strength of this nucleus lies in its core. So that is the hardest part which resists, division. So you need to weaken that area first. So this is 1.8 millimeter phaco tip which I routinely use. So I go ahead and drill in the center. So drill in center and drill deep within this nucleus. So I go ahead and do drilling. So the advantage is you are weakening the central core, and when you are chopping, you get a good purchase of the nucleus so that your chop becomes more effective and you can get through and through division of the nucleus. So here I am rotating the nucleus with side port and drilling in center. Don't try to drill till the capsular axis margin because you need this clean area for chopping. So once you have drilled deep within, now see, I'm going deeper, getting a good purchase, holding the nucleus nicely, and using a chopper to divide the nucleus. And you see the division is through and through anterior-posteriorly. And this is the division which we want in the first place. If you are able to divide the nucleus like this, it's become a child's play for you. So don't try to divide the entire nucleus across the diameter. If you have divided it like this, you just go ahead and rotate it 180 degree. Rotate it 180 degree, and again you can hold to one side with the phaco probe and chop the nucleus. So now you have the complete two division of the nucleus. So once you have division like this, you can again go ahead and divide it into further smaller pieces before. So this is the drilling part which we did in the center, which has weakened and made our chopping more effective. And you see the chopper is also not very sharp or something. We need good depth, we need good purchase, and we need good chopping to be effective, and the splitting actions which is required. Again see, we go ahead and divide the nucleus like this. So it prevents so then you can go ahead and make it into smaller pieces and take out the nucleus. In between, you should always replenish the OVD to protect endothelium. And the entire nucleus is out. And again, you do meticulous cortical irrigation aspiration and implant the IOL of your choice. So this is the hydroimplantation technique which I've been using for years. You just put irrigation cannula in anterior chamber and you can implant the IOL. So this was the first case. Let's see a case which is intumescent, and this case had attack of lens-induced glaucoma also. The challenge in these kind of cataract is the capsular axis part, which is very difficult to manage. So again, stain anterior capsule. And the technique which I love to do is sequential two-stage capsular axis. I try to make the very small axis in the central part, because this central part is the safest area where you can create capsular axis. This mid-peripheral part is bulging. It has liquefied cortical matter, and if you try to make axis there, it tends to go down towards periphery. So I go ahead and give initial just puncture and make it curvilinear. The moment you puncture it, you see the fluid comes out and you make a curvilinear tear. Here I am able to just complete it with cystitome. Otherwise, many times I need to use microcapsular axis forceps. And once you have made this smaller axis, you can go ahead and debulk the capsular bag nicely with 27 gauge cannula. So you just see the liquefied cortical matter which comes out, and once this matter comes out, it becomes a child's game to make capsular axis in this. So I go from other side port also, because it's not only one area, you need to debulk as much as possible. So I go ahead from other side port, see the amount of liquefied cortical matter which is coming, go from another side port and debulk. So once you have debulked like this, then you can go ahead and give a cut with micro scissors, give a tangential cut, and use Rexis forceps to complete capsular axis. See, it's very easy to do capsular axis now because there is no capsular pressure in the capsular bag. So you can get away with this. Again, the same technique is used. And one last case quickly I'll show is the Morgagnian cataract. We all know that the difficulty in these kind of cataract is again chopping to get a good hold because they are mobile nucleus. So once you puncture, a lot of cortical matter comes out, and so capsule axis is not a problem in these cases because once this matter comes out, it becomes easy to do capsular axis, but chopping is the main issue. So in these cases, the chopping which works best is to do the chopping from the equator because it's a mobile nucleus, it's difficult to chop. So go ahead with the bevel down and hold the nucleus, and once you have hold the nucleus nicely, bring it towards you and get the chopper from the equator. See the way it's rotating. Again, you need to hold it nicely and make the chop. So in this way, you can easily chop this nucleus in smaller pieces. So you need to be careful because there is no support cushion in the posterior capsule. So you need to take the nucleus upwards towards you when you are doing chopping. Get the chopper from equator and it divides the nucleus in smaller pieces, and then you can take this nucleus out. So this is how you can easily manage the Morgagnian cataract. I think because the time is less, I'll finish my presentation here. Thank you very much for your attention. Any questions? Thank you so much, sir.
Dr. Harshul,
Sir,
wonderful presentation. Just one question. What if you have a condition of phacomorphic glaucoma and the anterior chamber is very shallow,
Yeah.
0.5 or less?
Yes.
Then how would you enter that area and create space to move around?
Sir, I have a lot of cases of those kind also where anti-chamber depth is just 0.7. That even making a side port becomes so difficult that if you're not careful enough, you can puncture the anterior capsule at the same time. So the moment I make the side port, then it's always good to have OVD, which is space forming, so that you can easily get a space. And cystitome is, I think, is the least space occupying thing, which you can go from the side port and make a small axis in the center. So usually we get away. Once you put OVD, like sodium hyaluronate, something, it maintains the space which is enough for capsular axis.
Would something like giving a person mannitol before surgery help in such a thing?
No, I don't use, sir. I never use. And we do all cases under topical. That what I felt over the years is giving a block increases the volume like anything, and it puts you more in a trouble. Do all cases under topical. All cases under topical, which doesn't give any pressure from vitreous.
Thank you, Dr.
So we have described the technique what we put a 23-gauge trocar into the past planner, and then the liquefied vitreous comes out, and then we make the chamber.
I think for nanophthalmic eyes or those microphthalmic maybe, but for normal cases of Morgagnian or means intumescent cataract, we don't.
Surgeon of your caliber can perform it. I'm talking about the general difficulty, but that technique works very well.
No, but in intumescent cataract where you can't see actually, going blindly through past plana is not everybody's game.
White vitreous and some amount of warm vitreous comes out. That decreases the intraocular pressure and pushes the lens iris diaphragm back, creating a space into the anterior chamber. You don't go inside the vitreous cavity. Whatever comes out, because the IOP is high and the outside is at
Thank you, Avninder. Thank you, Dr. Harshal.
Thank you, sir.
Thank you.
I think what Sanjay was saying, no, even a mannitol sometimes works in these patients because that will decrease the vitreous volume and pressure goes down. And the technique described is a well practice. Some people do a little vitrectomy also and the pressure goes down immediately.
Some people also just push in a needle and suck out a little bit. Is that little bit also can give you a little space.
And this technique works out in those cases also where you have a sudden rise of intraocular pressure after you do a initial hydro procedure. Sometimes the fluid goes behind, and there also it's very, very handy. Thank you, Harshal.
Thank you, sir.
Terrific videos.
Yeah, very nice.
Now we invite Dr. Raj Sherkar from Bangalore, who will be talking on EDOF lenses, the new generation enhanced monofocal and multifocal lenses.
Thank you, sir. Respected Chair, Dr. Titial, Dr. Sanjay, and dear colleagues. So, in this video, I will not be showing you any videos of surgeries. It's a small change, but I may take you back to your school days of physics. So, so absolutely no financial interest in this. So, what are EDOF lenses? So, these are the lenses which can give focused image, the clear image over a range of distance. So, that's far, intermediate and near. So, even the trifocals and all these things, or even the wavefront based EDOF lenses, they come under the category of extended depth of focused lenses. What is the context in which we are talking? So, here we have an eye in which the crystalline lens may get opacified and we may have to remove that. So, we are speaking in the context of when we are going to replace that, what all functionalities of the normal crystalline lens we can bring back in the eye. So, crystalline lens has the dynamic ability to focus at various distances, and when it is focusing at a particular distance, there is also an image of the object that is in front and behind it also, which aids in the overall depth perception as well as stereopsis. So, here if you carefully look at the diagram, when the eye is focusing for near, even the pupil is changing. So, we keep saying the design of the body is so fantastic. So, when we try to see near, one of the components of accommodation is meiosis. So, that small pupil enhances the quality of vision as well as depth perception. This is one of the features that naturally happen. This is just to say how a convex lens focuses. The light rays, parallel light rays that come, they get focused to a point. This is what exactly the replacement we are going to give. And if you see the same convex lens in the previous diagram, it focused, this is a target which came from a particular point. Now, if you take...
This is the convex lens or the aspheric lens?
No, the general convex lens.
The convex
Just
lens will not focus at one point, no?
Yeah. This is taken as an ideal convex lens with one particular point of a small size, like physics point of view, not from the eye. Huh? So, it's supposed to have same power all over. No? It's an ideal kind of a thing. And then here, such convex lens with a fixed power, then if this is the object S, it makes a clear image at D. But what is S1, which is far away, may not come to the same point. So, it will come to a different point that's in front, and this another point which is ahead of this will come to a more distant point. That means if this is retina, some images will get focused at different points. So, that means it's not having a clear image of all the distances when it is focused at one point. While we replace the crystalline lens, we will be missing the dynamic range of focus. So, this is a limitation with which we are working, and constantly while we are saying that cataract surgery is very well advanced, we are also trying to say that trying to improve on the quality of lenses, and hence you keep seeing every other lens coming now and then. That's because the existing ones are not ideal, they are not comparable. How to overcome this loss of dynamic range of focus? Here we need to tweak the IOL designs and play with properties of light. So ideal replacement is another crystalline lens. While we are still not at it, if you take this first image, that is where one lens will focus here. Now, if the same power is given, it can focus the far objects, but when the same lens comes to the near objects, it's out of focus. So this is the limitation with which we are working. Now, how to overcome? So if you are clear at this point, this is a simple one. Now we will go one by one. Here, instead of a lens, I have just written a box, thinking, it may not be an ideal convex lens, but a tweaked one. Here in this case, the parallel rays, the D rays are coming to a focus at this point. The intermediate ones, which come from around 60 inches or something like that, they come to a focus somewhere here. And the nearer ones, they get focused very far. So this is the situation with normal lenses. Now, by tweaking this, suppose we achieve something where these lenses, after going through this magical box, they get bent little more, and this distance one, this gets bent little further away. We are just talking ideal situation, trying to overcome the limitation. Then we will be able to bring this point close to this and this point close to this. These 3 points will come closer. Now, is it possible? Can we bend the light rays? Then can we diverge these light rays is the question. Now we will look at various properties of the light rays. So this is the, by doing this kind of a tweaking, this is what we are trying to achieve, the nearness of these 3. By this, what happens? The quality of image from the distance, intermediate and near, all will be closer to retina, all will be nearly focused. An ideal situation is that coming to a very sharp focus and being in one line. But the ideal is difficult here, but it will come to a focus in a way that it has some kind of a tunnel kind of a thing will come. This channel will have width and also length. Suppose if that width is very low, that means all these light rays are converging here and becoming a line like, that means it's very, very sharp vision. Suppose if this length, this far and near and intermediate one, this is wide enough here, that means it gives a long range of vision. So that is the kind of one thing where we tweak these light rays and then try to achieve both sharpness as well as range of vision. Now another point comes. What about the quantity of light? Suppose 100x light is coming in. Now when it gets divided here, so will all the light come to the same focus, that is into the channel that we are talking, or some of the light is outside that? So in an ideal situation, we want all the 100 light to come into the channel, this kind of a channel here. But in reality, it doesn't happen. Some amount of light will go away. So now you have various lenses which try to bring in the light rays into one channel. They also try to bring all the light, but it failed. So now we need to see what are the various designs and how it happens. The various challenges we face are in the width of this tunnel. The width of tunnel is very narrow. You get excellent acuity of vision at distance, intermediate and near. If the length of this tunnel is long, you get a long range from say 30 centimeters to far away. But various lenses stop at various points. Now the light outside this, why are we concerned with the light outside this? Why are we concerned with the width of this tunnel? If the light outside is more, it causes halos and blur, and also it reduces the contrast sensitivity. So each lens has a different kind of approach. Now this would be the ideal lens. It will give all the near, intermediate and distance into one focus, and after the light ray bends, it doesn't diverge away, it goes in this kind of a channel. That's difficult because light doesn't behave like that. Then what are the various attempts? One is small aperture IOL, spherical aberration IOL, diffraction IOLs, and wavefront shaping of the optical principle. In small aperture IOLs, you just reduce the aperture and it will go. In spherical aberration IOLs, the peripheral light rays, they bend more than the central one, and hence it acts like a lens with a different focal lengths, and it can bring in a focus. But there will be challenges of halos and blur there. Then comes the diffractive set of lenses. These are one of the common ones which are used. Here you have these step-like things. Diffraction is one property of light where when light travels in straight lines, but when it goes through edges, some amount of bending of light rays happen. That's the diffraction. That property is used as an advantage here by creating those edges and making the light ray bend to our advantage. So in these diffraction, you have the height of this and the area here. The height here gives the near focus. That is where the light ray bends. The more taller it is, will give you more addition, near addition. And the more area here, this area and this area are important because that is where the light division happens. How much for near and how much for distance. So that's how the diffractive lenses are designed. And here again, halo effect is one issue. The edge effects that come are another issue. Another way of handling this thing is using the wavefront shaping of the light. I'll just take 2 minutes, 1 minute or so. This is where this is how the light goes. It has a Gaussian profile. In industries, this is used to make cutting in the iron. If you use this laser beam, this is how it cuts the iron piece. By putting a beam reshaper, this Gaussian beam is reshaped into this kind, and this kind of a punched out cut is possible in industries. Using this principle into eye, so this beam is reshaped in a way that it goes into this tunnel. By delaying this and converging this more, by reshaping the image. This gives this kind of a profile wherein though we are not able to get a thin line, but we are able to get narrow width and a long tunnel, long channel of light. This is where we are going to achieve in the current day wavefront surface modified IOLs. Here the advantage is the light distribution is better, light quality is better, and the range is continuous. Halos are less or nil. So this is, you can go through that. This takes time to analyze. There is one diagram which compares how each IOL behaves. And there are guidelines to classify intraocular lenses as which are EDOF category and which are not EDOF category. So lack of time, I am not going into that. And one small word, whenever these lenses come, kindly go through the manufacturer's guidelines. Current guidelines are it can't be used in children, and there are some contraindications also written, which your representative may not tell you. And if you end up using them and later on, if it doesn't commensurate with the recommendations, things may go wrong. Thank you very much. Thank you. Sorry for overshooting,
That was really good. Yeah, sorry.
Sorry for overshooting, it was physics, so I had to go a little slow.
Thank you so much, Dr. Shekhar. I think the most important, sorry, I always have to adjust the microphone to the height of mine. So thank you so much you rightly said, I think you concluded with a very important message that there are a few things that the manufacturers do not tell you and you should always keep in mind. So in my experience, what they also do not tell you and you also should keep in mind is there are two things. One of the things is out of the three principles that you just described, the diffractive design does not strictly come under the EDOF category. So let's just concentrate on the wavefront tweaking and the spherical aberration add-on. Out of these two, the photic phenomenon in my experience is more with the spherical aberration add-on type of lenses. So you have to be careful. The wavefront tweaking does reduce this photic phenomenon to a considerable extent, but I do differ greatly from what they have been telling us over the years, is that the EDOF lenses of whatever design they are, they do have a central bullseye change in whatever manner, and they are not, I repeat, they are not resistant to angle alpha. So if that central bullseye, wherever the change is made, is not very small and it doesn't occupy the center of the pupil, then you would have very disturbing photic phenomenon and does extrapolate to patients' discomfort and dissatisfaction. So they are not resistant to angle alpha. I'm still trying to study what should be an ideal margin or a forgivable margin for this. But I can't tell you the figure right now, but for me, the cutoff is 0.5. Beyond 0.5, I do not put it off. Angle alpha, 0.5. Beyond that, I do not put it off because I've burnt my fingers in a couple of cases doing that. Thank you so much, Dr. Shekhar. As we move on to the next talk by none other than Professor Tityal, and it's on important checklist for toric IOLs. Professor Tityal, all yours.
Thank you, and good morning, and it's going to be a good afternoon, friends. We all have been doing cataract surgeries, and in recent years, we all know toric IOL implantation, the percentage has increased because we have better knowledge of these lenses and better outcomes of patient receiving these toric lenses. And with the addition of multifocal lenses, the things have become much more important to realize what are the important, I think, checkpoints which needs to be done in these cases to acquire the outcome which can be given to these patients. So it can be a pre-operative checklist or intraoperative and post-operative checklist. Let me take you through one by one in these cases. Pre-op, you'll understand these are 4 or 5 basic important points. The one is the proper selection of patient, biometry, which is the most important part, TF film analysis, posterior corneal astigmatism, especially for a multifocal or a lenses for a premium IOS, then the accurate way of calculation of IOL power. So these are a basic, maybe some sort of cases where toric IOL may not be very suitable, but people still might do with a good back fixation in these cases, like a general instability. Poor candidates may not be a true hindrance for IOL for these patient toric IOL, but you can still put it. But these are patients you have to be very careful analyzing and counseling these patients appropriately to get a good outcome in these patients. So next point, which we all talk about for any surgery, that is important for cataract surgery also. You give enough time pre-operatively these patients. So your post-op chair time goes down once you explain these patients what are the basic outcome you are going to receive with toric IOLs. There are patients who desires to have both distance and near acuity, intermediate acuity clearly. Then we have to talk to them regarding the trifocal lens of these cases. Let's come to investigation point of view. I think one of the most important investigation in any IOL surgery, including premium IOL, is TFM analysis. Ocular surface disorder is a major concern for most of our patients in our country, and large number of patients at this age group will have some sort of dry eye conditions. So if you see this patient with a dry eye, treat that first, then go for surgery in these patients. So that is one important point we may have to understand the ocular surface problem for our patients. Second is acquiring good keratometric or a corneal power calculation or reading and the axial length calculation. The axial length we all understand. If you have a good optical biometer, that will give you a very, very accurate axial length recording for these patients. And if you have the ultrasonic waves and if you have well calibrated ultrasound system and one technician does it for every patient, you can still acquire a good outcome in these patients, especially for immersion biometry in these cases. So we'll say immersion and optical methods may be better. As far as corneal power assessment concerned, it is always better to use any device which you have been using, and calibration is important for these patients also. And always do at least 2 or 3 investigations from 2 instrumentations so that you can calibrate or you can analyze the readings which you have got. So if you look into corneal parameter wise, if your axis is similar in the 2 equipments, then that's a good case. If axis is not matching, then that may have a irregular astigmatism or ocular surface disease in these patients. So always try to do corneal examination or a keratometry in a virgin eye. Before any investigation, any touching of the eye, you should do a keratometric first. In fact, all our cases, we do a biometry as a first investigation, then we see the patient subsequently. To summarize the initial point of pre-op consideration, which are those patients which will be suitable, regular astigmatism of around 1 to 1.5. If you are doing a multifocal IOL, less than 1 diopter also has to be taken into consideration. In terms of determining the magnitude and axis is more important than magnitude because magnitude may change a little bit. Axis matching, that's a good case for you. Formula-wise, we should always look for the formula which gives you a nomograms based on a various parameters, which may have an online calculator. Look into online areas like www.asars.org. It gives you a nice way to calculate IOL power, which takes into consideration these some of the important points which I'll talk about. Intraoperatively, there are three important things. One is a proper reference marking, which you have given preoperatively. Then on the table, you are looking for access marking for these patients. And these are various ways you can go through and you can have access to these manual marking, image-guided systems. If you're a higher center, you may have an intraop abrometry also. So this is one surgery where I'm using the image-guided marking system, which is Callisto here, which gives you your orientation for incision, so that you're always in the same areas, which gives you orientation for your capsular axis, and sizing and shaping a capsular axis can also be important, very important aspect for getting good outcome for these patients. And ultimately, it will give you access for an accurate implantation lens in the axis of desirable, which will not shift more than 1 or 2 degrees from the desired axis. Because each division of shifting from the required axis can give you a lesser outcome for your patients. So this is what we'll like to do, aspiration of all quality care method, cleaning the posterior capsule, implant your lenses, and remove the viscoelastic from front and back. I think that is very, very important to avoid the post-op rotation in these patients. We all have come to know that post-op rotation does happen, especially within the first few hours and within the first few days in these cases. If you remove your viscoelastic appropriately, completely, the chances decreases. So this is what do. These are open loop haptic lenses. We keep around 2 to 3 degrees anti-clockwise after hydration, maintaining the anterior chamber pressure. Then we fix the lens to a proper axis. So tuck the lens clockwise, it will get right into axis, and this is how it completes the surgery. And similarly, you can achieve the same markings in the manual also. This is Mendy's axis marker, and the markings should be very sharp and fine. If you have a fuzzy margin, then again that will disrupt the orientation. See how sharp the margin is. Same way it can be done in these cases. Little bit on our cases with post-refractive surgery, post-RK, ectasia. You have to have a stable keratometry in these patients before you think of doing a toric or a multifocal lens in these patients. RK patient, if your central reading of keratometry is good, you can do a surgery in these patients. And in those patients where your cornea is irregular, then it may not be beneficial as such in these cases. If you compare manual versus automated systems, definitely image-guided systems give you a better result in terms of orientation of axis, and the quality of vision is also better with the image-guided system as compared to manual. And that is important to realize. The visual acuity may be similar, but the quality makes a huge difference there. The manual marking, I think pendular markings are better. Image-guided gives you a better analysis of your patient for good quality of vision, and useful again if you have an intraocular abrometry in these patients. Just a minute on a post-operative assessment of toric IOLs. 2 things are important. One is see the visual acuity of your patient post-operatively. Dilate. If you feel your refraction is not appropriate, do a refraction. Dilate the pupil. See your orientation of these 3 marks as compared to previous axis ways. So these are various ways to analyze your patients. It can be done a slit lamp, it can be ray tracing abrometry, or you can simply do a photographic method, then go into online software which gives you a www.astigmaticfix.com, gives you how you have to fix these cases. These are various ways where you can have misalignment, pre-op, intra-op, post-op, all 3 areas you can have misalignment in these cases also. Any case which has more than 10-degree rotation from the main axis may require a re-rotation. But that will depend on the visual acuity. If patient visual acuity is satisfactory, you may not do anything. If visual acuity is less, definitely you go for that. So this is what important point I would like to highlight towards the end. What are the basic point which makes you feel that you require a rotation? If your spherical equivalent is more than cylindrical power, so this patient may not benefit by rotation. If your cylindrical error is more than spherical equivalent, the patient may have a benefit after you do a rotation in these patients. So this is an example. If my spherical equivalent is 2 diopters, but cylinder is less, may not be beneficial here. Here, if you see the cylinder is much more than spherical equivalent, this patient might benefit. So to summarize the entire post-op analysis, check your toric alignment by dilatation, photographic methods. See the magnitude of required rotation, because various software will give you how much rotation, what you are going to achieve subsequently in these patients. Realignment can be done within a day, but it's better to wait for at least 48 hours, or don't wait for more than 3 weeks in these cases. And this is our review article, IGO. You can read and it gives you everything in detail. And thank you for listening. But if you have a heads-up device, you have a better orientation.
Thank you, Dr. Tityal. You converted a whole session into a very small summary and
Very small
very
capsule,
informative. Thank you so much. So, though we are running very short of time, we already crossed the time, but I would still request Dr. Radha Raman to make a brief presentation.
Yeah, good afternoon. I think we are overshooted the time, so I won't present any videos or anything. So we'll come to the point. Just, say when you consider any disease in the eye, the cataract and glaucoma is the most coexisting diseases. So most of the time glaucoma is managed medically, but when it comes cataract, you have to manage it surgically. When the question rises when it both are there and what to do with this thing. The medical management of glaucoma and perform cataract surgery alone or post-operatively continue the medical management. That is most of the time we are doing it, and some cases we will do the laser before the cataract surgery and we can. Or some cases when the IOP is not that controlled, we can go for the drainage surgery first. Definitely the cataract will increase and definitely you have to go for cataract surgery later. And how you decide it? Cataract surgery alone, when the glaucoma is controlled by a single medicine, better to go for cataract surgery alone. If you are a ocular hypertension, definitely you have to go for only cataract surgery. And surgeon is not that experienced, definitely you go for a cataract surgery alone. If it's an experienced surgeon, sometimes he will be going for more combined surgery than the cataract surgery. If the medicine requires more medicines and all that thing, controlled, if it is not controlled, definitely this thing. Then the question comes whether it's a single site or a two site. Single incision, single site is easier to do it, but less time consuming, but it has got its own problems. Pre-operative preparation is similar to any cataract surgery. Only question is whether to stop prostaglandins before surgery. Some people stop it. We can add with oral anti-glaucoma medicines. Pre-operative NSAID will be better. Steroid won't be that suggestible. Other option is to do it with SICS. That is also is accepted. When you consider the phaco surgery, it's a two-site means superior trab and temporal corneal surgery. We have other options also. In one site, it is, as I mentioned earlier, it is easier to do. No need to change the surgeon's positions. But the two site, you have to change the positions, and when you are applying mitomycin, sometimes it will take more time. And I am not going into the studies and all. The question I ask only is whether you all cases requires mitomycin C. My answer is no need to use mitomycin in all cases. In complicated cases, repeat surgery and all, definitely you have to use it. Older person with a relatively quiet eye, you need not to use it. If you are regularly failing in that type of cases, then you revisit your surgical technique. It is better to do it. The conjunctival management is a very, very important thing, and I am not going into the details of the surgical thing, but you should be very careful about trabeculectomy part. So phaco part, I am not going into it. So the incision is mostly, I am not running the videos totally. It's 3 into 3 millimeter superiorly. You punch it, and the next section people are very anxious, so I will short all these videos. And to conclude, take individual decision according to the patient and surgeon. Take all the precautions before surgery. Decide which patient to be referred to a surgical glaucoma specialist. That is a very important thing. If you are taking a risky cases, a cataract surgeon alone, you will be sometime in waiting for trouble. So maximum possible vision to the patient is our aim. Thank you for your kind attention, and sorry for the
Thank you so much, Dr. Radha Ramanna, for your wonderful talk and comprehensive. we conclude the session and hand over the chair to the next session. I hope the moderator and the conveners are there. But just before we do that, I would just like to take 30 seconds to expand Professor Tityal's talk on toric, which was very comprehensive as it is. In a vast majority of patients where the axial length remains in the normal range, whatever we discuss and whatever we do in the general sense is fine. But let's just talk about this small subgroup where the axial lengths are in the extreme range, the hugely hypermetropic and the hugely myopic eyes. We are blessed to have the Barrett's calculator, which does take into account the toricity ratio, so there's nothing wrong with the power calculation. However, in the hugely hypermetropic eyes, since the bag size is small, it tends to squeeze the IOL, and the ELP tends to shift a little anterior, causing a myopic shift over a period of time, which is not such a bad thing, because if the patient has a myopic shift in the long run, it assists in the intermediate vision. But in the myopic range, particularly if the wide to wide distance is more than 12 to 12.5, then the contact area of the haptic with the bag equator lessens a bit, so they're just likely to rotate a little bit. However good the material quality and the textured haptics may be, so they're just likely to rotate a bit. So I would prefer to counsel my patients for a possible refractive drift over a period of time, in myopic range in particular, and they might just need a touch-up therapy or might just need to. It also augurs well, because if the patient has a 0.5 astigmatism in the long run, which extrapolates to 0.25 spherical equivalent, it also assists in the intermediate vision to a sense, but you just have to keep it in mind is what I would like to give a message to the audience. Thank you so much, ladies and gentlemen, for the kind attendance.